So good afternoon, friends. We are here with the posterior segment videos, and we start with none other than Dr. Mallika Goel herself. Fibrin glue for closing retinal breaks in complex retinal detachments with silicone oil in situ.
Thank you very much for this opportunity. Basically, I don't know how many are retina here, but this started with us 2 years back when we were in a desperate situation. We operated a complex PDR RD and it failed because there was a break which was not closing on the table. So I thought, okay, anyway, this eye is lost, vision is anyway going to be lost. So let's just put glue, and if there are any complications from glue, it doesn't matter because anyway it's a blind eye, going to be a blind eye without success. So that is how it started, and we found no complications, and in fact the success was very rewarding. So hence from that time we started using for all cases. Audio है इसमें? कर दो. Should I give on a pen drive? So following that, we have used it for many cases of PDR related RD because we are not able to do laser in these cases because of bleeding on the retina. PowerPoint, free paper. Audio is the problem. Fibrin glue to close retinal.
मैं स्विच कर रहा हूँ, आप ये कर दीजिएगा स्विच करने के बाद.
Yeah, it was used earlier as a primary procedure because I was aware that it can be used, but that was not being used for complex RDs with oil. It was done, yes, that break, and there was no tamponade added. In fact, it was being done so that no tamponade was required. But no, this was not done. Yeah, absolutely different, yeah. So, in complex
Can we
retinal
start?
detachments with oil in situ.
Yeah, please start.
Fibrin glue has been used for retinopexy in surgery for simple rhegmatogenous retinal detachments, but there it is used to close breaks to obviate the need for oil or gas tamponade. It has not been reported for complex retinal detachments with silicone oil injection. Our first case 2 years back was PDR with combined traction rhegmatogenous retinal detachment that did not succeed. The retina remained detached with a mid-peripheral superior break. So we took her up for resurgery, but could not laser this break even during surgery after additional membrane peeling. So this break was closed by installation of fibrin glue, and we found rapid retinal reattachment in the post-operative period. And this same patient is doing well 2 years after surgery with good vision, intraocular pressure, no inflammation, and the oil has not emulsified, though we have removed the oil recently with an uneven filter. Subsequently, we operated more retinal detachment with this technique. Due to membrane peeling, there are some retinal breaks. The blood is not easily removed from the surface of the retina. The laser cannot be done for these breaks. Fibrin glue is being instilled over these retinal breaks. There are two components of the glue, and each of these is instilled sequentially over each of the breaks that cannot be lasered. And you can see that in the first post-op week, the retina is attached, the glue is resolving by the 3rd week and is gone by the 5th week. Another patient of PDR-RD, bleeding during surgery. These breaks cannot be lasered, so these are being closed by installation of the two components of fibrin glue sequentially over each break, with a good post-operative result. In this patient, the break is very close to the foveal center. So after membrane peeling, fibrin glue is instilled over the break to avoid laser near the macular center. And on the first post-op day, the glue is closing the break successfully. And by the 6th day, the glue is gone, hole is closed, and retina is attached. Another patient of PDR with complex RD. At the end of surgery, there's a break which cannot be lasered successfully. So the break was closed with fibrin glue. And you can see on the first post-operative day, the glue is seen, the break is closed, and the retina is attached on day 1. And this is the situation after 2 months of surgery. Another patient with a PDR-RD. As membrane peeling progresses, there is a retinal break near the macula which cannot be lasered. So we instilled fibrin glue over this break. And you can see post-operatively, retina is attached. And even after a year, there is no oil emulsification, pressure is normal, and the eye is stable. So we have extended it to non-diabetic indications, especially for macular hole retinal detachments where ILM peeling is not possible. For example, this was a patient operated thrice for retinal detachment with macular hole. We instilled glue over the hole, and you can see that the macular hole closed and the retina is attached with good recovery of vision. Another boy with a chronic retinal detachment, macular hole was the only break that had caused the detachment. So at the end of surgery, glue is instilled over the break, over the macular hole. And on the 6th post-op day, the glue is seen covering the hole. By the 10th day, the glue is gone, the hole is closed, and the retina remains attached even a year later. Sometimes the macular hole may remain open, but the retina reattaches, and that's also a good success. For example, this patient operated thrice for macular hole, did not close, on the other hand developed a retinal detachment. So at the end of surgery for retinal detachment, we have instilled glue over the macular hole. And you can see on the first post-operative day, the glue is closing the hole. Retina is already attached on the first post-operative day and continues to remain attached. There is some subretinal glue which resolved rapidly. With regard to technique, check the needle tips for blockage immediately before entering through the sclerotomy, because blockage is common, and attempts to overcome the block close to the retina causes the liquid to come out with high force, which can enlarge the retinal break and lead to excessive injection. Avoid excessive injection, just 1 to 2 drops of each component is adequate. This is difficult because each component is transparent, and even after contact of the two components, the glue remains transparent for some time. So the surgeon does not clearly visualize the injected amount. As far as possible, it's better to use the more viscous sealer protein, which has a blue top, first. This allows overall less spillage. And the two components should be drawn into two different 2 ml syringes, which are easier to maneuver than the 1 ml syringes, which are longer. Fibrin glue migrates subretinally through a macular hole, as we saw in one previous case, and in this case we can see the glue on the scan. And though the glue does resolve in a few days, but if this is a macular hole or close to the macula, any atrophy ensuing from the subretinal glue can cause visual loss. As we noted in some of our patients where there was subretinal glue, the track showed subretinal atrophy after a few days. So glue should not be used for regular closure of macular holes, but only in cases of resistant macular hole RDs. Also, in a peripheral retinal break, excessive injection should be avoided because it goes subretinally and keep the break open. And we had a case where we had to reoperate to attach the retina because of this. To conclude, fibrin glue can be a useful adjunct in the management of complex retinal detachments, especially associated with PDR, when laser for retinal breaks is not possible due to bleed, retinal edema, proximity of the break to macular center, or the macular hole RD itself. The glue is not seen as early as 1 day to 4 weeks after the surgery. There is rapid retinal reattachment, and the need for post-operative position is reduced or even eliminated because now the situation does not require silicone oil tamponade of the breaks. We did not see any long-term adverse effects with silicone oil in situ. There was no inflammation, no IOP rise, and no oil emulsification in the 24 months of follow-up. However, we should avoid routine use for macular holes as it can cause retinal atrophy when it migrates subretinally, affecting the visual outcome, and avoid excessive injection as it can move subretinally and keep even the peripheral breaks open. Thank you very much.
Thank you, ma'am. Thank you, Dr. Malik. That's good. Even in macular holes, you have used oil in all these cases.
Macular hole RD. These are not
Yeah.
macular holes.
These are macular hole RDs, and
Yes.
all these cases underwent a silicone oil injection
Yes.
and later on removal of silicone
Yes,
oil.
and these are chronic RDs, already
Yeah.
operated once or twice. For many years, the RD has been there. So oil would anyway be used in any case.
Okay.
But we can't do laser for the macular hole.
Yeah,
so
of course.
we might put a glue there, and these cases have all resolved.
So this is not like, would you recommend it as a first line instead of a cryo or laser for
No,
RDs?
not first line because not first line because laser we know we can see the scar. It is for lifetime.
Yeah.
So I think mindset is still geared to that only right now. But maybe it will change later on. But as of now, we only do it in resistant patients.
Thank you, ma'am.
Thank you.
Have you presented it before, ma'am, like this?
I have presented it last year AIOS, and
Okay.
I mean in midterm, and also at ASRS, American Society Retina Specialist.
No, but like, did you get an award last year because
Yes, I got the award last year, yes.
for the same?
Yeah, but the number of cases has changed. That time it was only for PDR, 4 or 5 cases. Now
Okay.
I've extended the indication to macular hole RDs, and all these videos were not there that time.
So this is a different study.
It's a additional indications and cases.
Thanks.
Thank you. One of the situations where I particularly feel it's useful is where the SRF does not completely come out. You aspirate with suction, but the retina still remains elevated, which is very common in complex RDs. You must have noticed. Yeah, I do not know the reason. We keep on aspirating, but there is no apposition. So there, laser will not happen because there is no apposition. So there I find it so useful. You just go and drop it, and you don't need positioning even because now you're not depending on the oil for closing these breaks. Thank you.
Posterior segment intraocular cysticercosis, the good, the bad, and the ugly.
A patient once came in ophthalmology outpatient department during my residency with complaints of diminution of vision in eye associated with pain, redness, floaters, and periorbital swelling. After taking her vision, I took the patient for examination, during which I was amazed at what I saw. I saw a yellow ball playing hide and seek with the light. To this, the exhilarated me shouted, "Sir, I can see a yellow ball moving in the vitreous cavity." To which my sir started, and I quote, "Ocular cysticercosis is a preventable cause of blindness caused by larval form of Taenia solium called Cysticercus cellulosae. Humans usually ingest the egg form of the cystode through contaminated food and water." After some meeting about the symptoms and other ocular manifestations of ocular cysticercosis, he said, Cysticercosis involving the posterior segment of eye usually involves the vitreous cavity or subretinal space. It may be associated with variable RPE disturbances, intraocular inflammation, and retinal detachment. In this video, we demonstrate diverse presentations of a few cases with posterior segment cysticercosis and some practical pearls to manage those situations. Our first case is a 40-year-old female who presented with a large intravitreal cysticercosis extending almost up to posterior lens surface. She was planned for PPV and cyst removal. After making standard scleral ports, a large cyst with live undulating scolex was noted in vitreous cavity. The cyst was rapidly engulfed with cutter within the vitreous cavity. Triamcinolone was injected to ensure complete haloid removal. Thick fibrous membrane was noted at the site of cyst, which was gently removed with the help of cutter and ILM forceps. This is important to prevent postoperative pervisual inflammation, ERM formation, and retinal detachment. Peripheral vitrectomy was completed 360-degree and endolaser was performed around the cyst site. Hence, intravitreal cysticercosis can be engulfed in the vitreous cavity by cutter without in toto external cyst removal. Complete removal of all debris and membrane are essential. Our second case is a 50-year-old male who presented with a large submacular cysticercosis. He was planned for PPV. After standard 25-gauge scleral ports and core vitrectomy, posterior hyaloid was removed, ensuring cyst integrity. Any inadvertent subretinal cyst rupture may cause intense inflammation. A retinotomy was made on a suitable location. Temporal Parsplana approach was considered as it was a very deep-seated eye. A constant but gentle suction was created with a 25-gauge silicone tip to extrudize the cyst in toto from subretinal space to the vitreous cavity. It was engulfed with cutter thereafter, followed by fluid air exchange, endolaser, and siliconal tamponade. Hence, 25-gauge silicone tip assisted suction is an effective way to remove subretinal cysticercosis. A retinotomy can be planned in a favorable position. Temporal Parsplana approach may be adopted in a deep-seated eye. Our third case is a 23-year-old male who presented with an intravitreal cysticercosis and associated total RD with extensive PVR changes. Following core vitrectomy, intravitreal cysticercosis was engulfed with cutter. Underlying narrow funnel retinal detachment with extensive PVR membranes were noted. After partially dissecting the posterior vitreous membrane, PFCL was injected to flatten the posterior retina. Standard steps of retinal detachment surgery were completed thereafter. Hence, posterior segment cysticercosis with RD and extensive PVR changes has guarded prognosis. However, PPV may be attempted to prevent thigh cysts and achieve ambulatory vision. Fourth case is a 35-year female who presented with a small subretinal cysticercosis in left eye. Cyst enlarged significantly over next 4 weeks. Although advised surgery, she did not consent and was lost to follow-up. Came back after 6 months with leukopodia and a narrow funnel RD on USG. She progressed to panophthalmitis and required evisceration finally. Hence, untreated submacular cysticercosis has a high risk of spontaneous rupture. It may lead to panophthalmitis requiring evisceration. To conclude, PPV is mainstay in managing cases with posterior segment intraocular cysticercosis. Early surgical management is essential to prevent irreversible visual loss. Appropriate preoperative evaluation, use of proper instruments, customized maneuvers, and intraoperative adjuncts in individualized way may help in achieving favorable outcome. Thank you.
Thank you. Thanks. Are you a ratified member?
No, I registered last year. I'm a resident actually. I
I
registered.
think you are not yet ratified.
No, it's been more than a year for this. So,
With the 28,000 package, 28,934. It was nice presentation. You.
So next in line we have Dr. Akshi Sharma. Is she here? Dr. Akshi? No. So can we have Dr. Vaibhav Bhatt, who will be presenting on third hand and third eye in VR surgery.
Good afternoon, everyone. So I'll be starting with my video.
Next 5 minutes, you all will be witnessing PFCL assisted inverted ILM flap technique for large and recurrent macular holes. First case is a 59-year-old female presented with diminution of vision in right eye. BCVA was 6/60. Fundus examination revealed large full thickness macular hole. OCT showed stage 4 macular hole with basal diameter of more than 900 micrometers. Patient was taken up for 25 gauge sutureless vitrectomy. ILM was stained with BBG dye. Inverted ILM flaps were rolled towards macular hole edge. Plugging of macular hole was attempted, but as seen on intraop OCT, the flap failed to cover the hole completely. PFCL was then injected, and under PFCL tamponade, the ILM flaps were mobilized using 25 gauge loop towards the macular hole. And apposition was confirmed on intraop OCT. Fluid air exchange was done and PFCL was removed at the end to ensure flaps remain in position. Tamponade with C3F8 was used. Post-op fundus examination revealed closed macular hole. Post-op OCT showed closed macular hole and vision improved to 618 parts. Second case was a 50-year-old male who presented with full thickness macular hole, for which he underwent primary surgery with inverted ILM flap and C3F8 tamponade. 4 weeks post-surgery, patient presented with recurrent macular hole. Which was confirmed on OCT. Patient was non-compliant to post-op positioning. He was taken up for resurgery. PFCL was injected and ILM flaps were repositioned and mobilized using 25 gauge loop towards the macular hole under PFCL tamponade. Intraop OCT confirmed closure of macular hole. Fluid air exchange was done and PFCL was removed at the end to ensure flap stability. C3F8 tamponade was used. 4-week post-op fundus examination revealed closed macular hole, which was confirmed on OCT and vision improved to 612. So our last case was 68-year-old male with history of macular hole surgery elsewhere, presented with large refractory macular hole in left eye with 3/60 vision, with basal diameter of more than 2000 micrometers. Vitrectomy was completed. Nasal and inferior peripheral retina were found to be detached. Meticulous vitreous-based dissection was done. Intraop OCT confirmed the magnitude of the crater. BBG dye was injected. However, no residual ILM could be found around the hole. 25 gauge chandelier was fixed at 6 o'clock position. PFCL was injected over posterior pole. BBG dye was re-injected, but useful ILM could not be mobilized. It was time for plan B. Diathermy was used to mark area of retinal harvest in inferior detached retina. Retinal autograft was fashioned bimanually using 25 gauge forceps and 25 gauge scissors. Graft was carefully transferred under PFCL and placed over macular hole using two 25 gauge forceps. Graft was gently spread with closed 25 gauge forceps tip to cover the macular hole. Intra-op OCT confirmed coverage of macular hole with retinal autograft. Air fluid exchange was done. SRF was drained through retinotomy and PFCL was aspirated at the end. Endolaser was done around retinotomy and retinal break. Silicon oil was injected. Post-op retina was attached under silicon oil. Macular hole was plugged with retinal autograft and vision improved to 636. While reviewing literature, I came across few articles. Vishal Agarwal et al. Did a comparative study between inverted ILM flap technique versus standard ILM peeling technique, where they concluded that inverted ILM flap technique had significantly higher anatomical closure and better visual outcomes. In this, they injected PFCL and under PFCL they fashioned ILM flaps towards the macular hole edge and rolled up inside the edge. Sin et al. Described PFCL assisted single layered inverted ILM flap technique for macular hole. In this, after fashioning the flaps, they injected PFO over the inverted ILM flap and repositioned the flap under PFO. And then at the end removed the PFO during fluid air exchange. Abdul Qadir et al. In their review article stated that there is robust data supporting inverted ILM flap as first-line management for large idiopathic macular hole. Other surgical options include autologous retinal graft, human amniotic membrane, and distal ILM flaps. So to conclude, PFCL-assisted inverted ILM flap technique can be used as primary approach for large, chronic, and recurrent macular holes. PFCL acts as an efficient third hand, and intra-op OCT is useful third eye adjunct in achieving successful outcomes, and loop is a useful tool for performing such complex maneuvers. Thank you for your attention.
Thank you.
What was the vision?
Last case as in
The silicon oil with the
636, sir. Finally he achieved a 636
after
vision.
oil removal.
Yes, sir. Yes, sir. After oil removal.
Thank you.
Thank you, sir.
Viral was managing retinal detachment secondary to ARN. She's here? Okay. Then we will move to eye intruder strategies for intraocular foreign bodies. Pushkar Dheer.
Good evening, everyone, and good evening, judges. So I'll be presenting only one case, which will be showing that how the instrument can be a limitations in challenging.
We present you
cases
a
with large
35-year-old
intraocular
gentleman
body.
from Haryana who suffered from ocular trauma due to road traffic accident. On examination, his vision was found to be counting finger close to face with full thickness corneal penetrating injury with iris and vitreous prolapse. On gentle B scan examination, high spike decodes with backshadowing was noted, which suggested of intraocular foreign body with subhilar hemorrhage and retinal detachment. A plan for primary as well as secondary repair was made on table. After making the side put and injecting the viscoelastic, prolapsed iris tissue was saved as much as possible and corneal suturing was done. Once the tight chamber was found, plan to go for posterior segment exploration was made. 23 gauge 3 ports were put. Since inferotemporal and superior-nasal ports had choroidal areas, ports were reinserted and one more port at 6 o'clock was made for the chandelier light. Inside the vitreous cavity, a glass foreign body was noted on the posterior pole. We did a core vitrectomy followed by PFCL insertion to protect the posterior pole. Corneal serial section was made to take out the intraocular foreign body. IOFB forceps was tried to pick up the glass foreign body, but due to its large dimension and orientation, forceps was not able to grasp it. Decision to make temporal scleral section was made, but due to heavy bleed at the side, the sclerotomy approach was cancelled. Multiple attempts with IOFP forceps, McPherson, bimanual serrated forceps were made, but due to heavy and large size, IOFP fell back. Finally, remembering the Thirsty Crow story, we decided to put more and more PFCL with dragging of IOFP along with the retinal surface, along with indentation on the external side with the help of muscle hook. IOFP gradually moved up and we made sure it doesn't dip back into the PFCL due to its weight. Once in the anterior vitreous area, we used the vectors to entangle the foreign body and with great difficulty we took out the IOFP. Certainly there was trauma to the iris, tissue, corneal endothelium and the retina. Once IOFP was removed, we carried on with the vitrectomy to settle the traumatized retina. And while we were removing PFCL, the PVD occurred, and we did PVD till the equator. After that, we injected more and more PFCL, flattened the retina, did a 360-degree endolaser, and finally did PFCL oil exchange. We did try for fluid exchange after making retinotomy, but due to extremely compromised view after 2-3 trials, we did direct PFCL oil exchange. The section was sutured and ports were removed.
Apologies for a very traumatic video, but honestly having this irregular, a very large foreign body which was approximately measuring 7 mm in length and 2 mm in width was a real trauma to the eye, and it's very difficult when it's a irregular foreign body and you lack a proper
This is 1 week
instrumentation.
post-op picture with BCL. Patient vision was counting finger close to face still with anterior chamber formed and oil-filled vitreous cavity. Hazily the disc was seen and retina seemed to be attached and in good shape.
The take-home message from this is two things. Though the vision remained very much the same, but it didn't deter me to continue the surgery. It took me around 3 hours to complete this surgery. Secondly, what I learned from this surgery is when the foreign body had touched the retina. Because I lacked instrument to pick this foreign body up, so I had to use a muscle hook for external indentation, and gradually I kept on filling the PFCL oil, and that's how the foreign body came up. And then I had to take it out. Maybe I could have enlarged a little bit of more section, would have helped me to take it out in a one go. But that was the learning point. And the second main important point is when the foreign body has touched the choroid, retina choroidal surface, it's better to do a 1 mm of choroidectomy, which is actually a Cohen's technique, which helps to prevent further PVR changes, which I experienced in this patient later on after 2 months, that there was a PVR changes which was developing at the site of the trauma itself. Thank you so much for patiently watching this.
It was a very challenging case. Did you put belt buckle in such cases?
No, ma'am. See, initially there was no RD per se. The RD happened when the foreign body was being removed. So it was a continuous manipulation which was happening. There was no instrument to pick that foreign body up. And you are in a lurch whether to leave it. It's an inert foreign body. So whether to leave it in the primary repair, but when I had made a choice of going beyond, going posterior, then there was no point that I should leave it in C2 and come for the second surgery. And the view which I was getting at the primary surgery, I might not be able to go for the second surgery. Keeping that in mind, I went on and tried to remove it. So probably while it was coming in the anterior part of the retina, there was a certain amount of trauma to the retina which led to a break, and then the surgery became more complex. So this thing that came to my mind was that using a muscle hook from the external surface and toppling the dragging the foreign body up was the thing which helped me out. Otherwise, I was finally leaving it up because there's no instrument which was able to pick it up. The clawed forceps, the IOFB forceps was not able to bear the weight, and the orientation was not happening to the level that I should be able to pick it up. So
in that scenario, I think it was
glass foreign body.
glass foreign body.
So I
But
have no
you
magnet.
okay, thank you.
So no magnets and also. Thank you very much.
You've been able to remove oil later on.
So yeah, so that's the later part of the story. So what the lesson I learned is, so I had PVR changes after 2 months of period, and then I realized that how difficult it could be, and then I tried to move the retina back and all, and finally the patient is off oil, but I could still see a lot of PVR changes. The vision is pretty much the same, counting fingers only. So the only solace with me is that I removed the foreign body and I learned it a hard way. So probably I could have done a choroidectomy at the same time, at the point where I can see the PVR changes, it would have changed the final scenario. So that is the take-home message.
I think that the large scleral wound, and that too at 2 places, kept
Right.
The eye being soft every time.
Right.
So that was another challenge which you were facing, and of course the hazy view because of a bad cornea.
Corneal wound.
So lens was already managed.
The lens I removed, did the lensectomy itself. because-
Lensectomy also.
Yeah.
Okay, good.
So it was a Thank you.
Thank you.
Thank you.
So he will speak on be a recycler, be a saver today, recycle for a better tomorrow.
Thank you. In fact, the patient was also happy that he has got some refund also of the IL charges.
Nice video. Have you ever tried retrofix iris claw?
No, sir. Usually in our hospital, we usually do by this method only. Actually.
That can be a easier option and a quicker option if you have.
We'll try, sir.
You already had a tunnel which you could have opened and removed the lens.
Yes.
But this was a 3-piece lens, so you can always fix that. So it's good. Thank you.
Thank you, sir.
Dr. Akshi is still not here, no? Not yet. So I would like to invite Dr. Gagan Bhatia, a prolific surgeon from Delhi, to present on human amniotic membrane graft for the optic disc pit maculopathy.
A 15-year-old lady presented with diminution of vision in the left eye for 1 month. She did not give any significant systemic history. On examination, her best corrected visual acuity was 20 by 20 in the right eye and 20 by 80 in the left eye. Fundus examination of the right eye was within normal limits. The left eye showed a neurosensory detachment associated to a small excavation in the disc, suggestive of an optic disc pit with neurosensory detachment. The patient was planned for a vitrectomy with macular sparing ILM peel, amniotic membrane grafting, and cast tamponade. After PVD induction and a complete vitrectomy, brilliant blue dye assisted macular sparing ILM peel was initiated. A small cuff of ILM is carefully preserved at the temporal edge of the disc. The amniotic membrane, popularly referred to as HAM, is stained with brilliant blue dye, which helps in safe handling and visualization of the thin and transparent membrane. We measured the pit size on OCT preoperatively, and an innovative way, we use a dermal trephine to procure a perfect size graft. 25 gauge microforceps are used to separate the graft from the paper. Very careful handling of the graft is done by manually in the vitreous cavity using a 25 gauge microforceps and a Tano scraper. Finally, with the help of the Tano scraper and a nitinol loop, the graft is unfolded and gently tucked over the pit in place. The preserved ILM cuff is inverted over the graft. Fluid air exchange followed by gas tamponade is done to complete the procedure. On post-operative day 1, we see a well-attached retina and absolutely dry macula. The 3-month follow-up period was uneventful and showed a complete resolution of the NST and no recurrences were noted. The patient improved from a BCVA of 20 by 80 to 20 by 40 post-operatively. Microperimetry at 3 months was comparable in both eyes with few minor losses seen in the left eye.
Thank you.
It was a nice case presentation. Any laser was done around the optic disc pit?
Never.
No.
So basically, the idea of using human amniotic membrane came from. So there was a series which I had presented many years ago where we had used all three techniques. We had done laser, then we had done active fluid suction through a 41 gauge cannula, and we also done a macular sparing peel. So all three were different series, and that is when we realized that none of the patients, finally there was a lot of reoccurrences, and even literature says the same. So optic disc maculopathy is very difficult to treat. With this human amniotic membrane, we first started using human amniotic membrane with recurrent macular holes, and then we kind of thought that why not just use it in optic disc pits as well. So so last week only, I think this was accepted for publication in a Journal of Vitreoretinal Diseases with Stanford, where we've basically described the technique, which is a triple S technique, which is basically how to procure a human amniotic membrane graft, because most of them, because cutting it and sizing it to such a small size is extremely difficult, and especially even for macular holes. As far as optic disc pits are concerned, there are at least, now we have a series of around 5 or 6 cases, because they're very rare to find, that is one. And even as you just pointed out, laser, so there is one child, that most of them are pediatric. So there is one child who again has had a laser, and that kind of reoccurred, a laser done elsewhere kind of reoccurred after 4 or 5 years. And that child I operated just last week, so they're doing fine. So I think this seems to be a little more promising than the previous techniques that were described. But let's see what happens in the future.
So maybe glue will help us in future?
Yeah, but sir, the point is that even if you see in these cases, and then I now have this case follow-up, I have almost till 5 to 6 years now, 5 years now. The thing is that the graft still kind of, it plugs it. We don't know about glue, and we really don't know where it will go. That's the only thing, that where will the glue go. And toxicity is also something which is there. Yeah, because one is that where it will go, that is the biggest problem, where it will go. And in this case also, like, I have not used PFCL, never used anything. It's just been, I think you just decreased, I mean, if you're using an active infusion, just decrease the infusion, and and stop the active propulsion thing. And then I think that it's just about holding it and putting it over there. And I think we've devised this, used many instruments to do it. So I think nitinol loop and a blunt tano, it's not a usual tano scraper. I mean, you basically shave off the diamond and then you use it without the diamond, so then it kind of opens up.
This is the finesse loop.
This is the finesse loop and the tano brush, which is the... Yeah.
So these dermal
Tripfines,
they come in different sizes?
Yes, sir. They come from 0 to 5 and they are extremely cheap. They're only 250 rupees. And this we realized after buying a very expensive...
Is it like the one which they use for hair transplant?
Yeah, same.
Yeah.
Same, exactly
hair transplant.
Same. Yes, exactly same.
Good.
Yeah.
Thank you. So the last presentation, silicone oil retaining suture for uveitic hypotenuse eyes.
Good evening, everyone.
The following video is a case presentation on silicone oil retention suture technique for uveitic hypotonous eyes. Ocular hypotony is defined as intraocular pressure less than 5 millimeters of mercury. There are multiple causes leading to ocular hypotony, most commonly being ocular trauma, chronic uveitis, and intraocular surgeries. Ocular hypotony poses a challenge both in terms of medical and surgical management. There are multiple studies which quote that if left unattended, ocular hypotony can lead to a number of complications like choroidal detachment, hypotony maculopathy, hypotonic keratopathy, optic disc edema, ultimately leading to progressive visual loss and phthisis. The last image showing a prosthetic eye. The surgical management of ocular hypotony includes pars plana membrane cleaning with release of traction over the ciliary processes and silicone oil injection for tamponade. The main postoperative concern in aphakic eyes is anterior migration of oil, which ultimately leads to corneal decompensation. So what can be done? We know the answer. Silicone oil retention sutures are placed 1 mm posterior to the limbus and act as a barrier between silicone oil and the anterior chamber, preventing its contact with the cornea. Much like the line of control, our soldiers protecting our country from intruders. How does it work? The surface tension of the silicone oil aqueous interface is high, and hence the silicone oil maintains its integrity as a spherical shape and the sutures work as a barrier. A 57-year-old female patient presented to the OPD with visual acuity in the right eye being hand movement and intraocular pressure of 8 mm of mercury. She was diagnosed with idiopathic chronic uveitis with chronic hypertony and complicated cataract. B scan showed thickened coats with disc edema. The patient underwent cataract surgery under cover of low-dose oral steroids. The UBM showed thickened ciliary body with blunted ciliary processes with membranes covering the surface. The posterior capsule is plastered to the iris with bulging of the vitreous phase, as is also seen on the anterior segment OCT. Hence, we decided to go ahead with the surgery. 3 25-gauge pars plana sclerotomies were made. Core vitrectomy was done. The posterior capsule attached to the iris is cleared and base shaving is completed by peripheral indentation. As it is a non-dilating pupil, 4 iris hooks are placed. The most crucial step is the dissection of membranes over the ciliary body. Extensive external indentation of the pars plana region allows adequate visualization of the ciliary body. The membranes are released with intraocular forceps without causing undue pulling, and then cut with low vacuum high cut rate settings. This procedure is repeated at all clock hours. Once completed, the iris hooks are removed. Limited conjunctival peritomy is done at 3 o'clock, 9 o'clock, 12 o'clock and 6 o'clock. Four partial thickness scleral incisions are made tangentially at 3 o'clock, 9 o'clock, 6 and 12 o'clock, 1 mm posterior to the limbus. 9-0 polypropylene straight end suture is passed through the scleral grooves from 330 to 830 and brought out on the opposite side with the help of a 26-gauge bent needle. The next suture is passed from 230 to 930. The same procedure is repeated vertically with sutures passed from 630 to 1130 first, the final suture is then passed from 530 to 1230. The sutures are tied and the knots are buried. Inferior peripheral iridotomy is done at 6 o'clock with the help of a cutter. Fluid air exchange is done. 5000 centistoke oil is injected. The flute is used to remove the residual air bubble and the silicone oil is filled up to the level of the sutures. The ports are removed and sutured with 8-0 Vicryl. Post-operatively, the patient is doing well with visual acuity of 6/30 in the right eye, with intraocular pressure maintained more than 8 millimeters of mercury. Anterior segment shows well-centered polypropylene sutures preventing the forward movement of the silicone oil. The wide field fundus imaging shows well-settled retina with sutures in place. Posterior segment OCT shows few choroidal undulations with well-settled retina and mild macular edema. There are multiple patterns of silicone oil retaining sutures, namely triangular, star pattern, H pattern, trapezoid, and square pattern, which is selected based on the surgeon's convenience. The pros of this procedure are: it is cost effective with no added trauma, failure does not alter the course of treatment. The cons include: it is less effective in very severe cases of hypertony, technically challenging for beginners, and newer techniques available are aniridia IOLs and vitreous bag implants. To conclude, silicone oil retaining sutures remain one of the most effective ways to prevent oil migration to the anterior chamber in aphakic eyes, and hence prevents cornea related complications. Designs can be modified based on the surgeon's preferences. Thank you.
Nice, thank you. So you could achieve a visual acuity of 636.
Yes, sir.
That's great.
And the pressures were maintained more than 8 millimeters of mercury, which was approximately 2 before surgery.
Yeah. And you plan to keep this oil in situ for long?
We've put 5,000 centistrokes,
Yeah.
sir. So right now we've almost achieved 8 to 9 months of follow-up. So right now the patient is doing well. Maybe in some time we will think of removing it. Let's see.
That's good. Thank you.
Thank you, sir.
So is there any other presenter who might have missed, we might have missed? So thanks. I think then we'll conclude this session with the well in time, before time. Thank you. And we'll have a group photo with the presenters. Please stay.